My name is Robert Lerrigo. I am a gastroenterologist, just graduated fellowship from Stanford, and I have a special interest in inflammatory bowel disease.
So I was wondering about biologic drugs and how long a patient on a biologic could typically expect it to be effective. I know there is some risk of developing antibodies, I believe, to the drug, and what's the risk of that happening?
Yeah, so drugs lose their effectiveness for a variety of different reasons. People may not just be responsive to that drug in general because their flavor of Crohn's disease or ulcerative colitis um, just doesn't respond to that mechanism that the drug targets. So those are kind of people who are kind of what we call primary non-responders. There are people who develop a response initially and then lose response down the road. And those people may lose response because there's not enough drug in their system. It may be because they are developing antibodies to the drug, and the antibodies are removing the drug from their system, in their blood. So there are a whole host of reasons. There are different risk factors for developing antibodies to drugs. Okay, so when our body mounts an immune response to these biologic agents, and they're biologics for a reason, right? So these drugs are called biologics because you're injecting a protein in the body, and these proteins are antibodies themselves, but it's a foreign agent. So your body is at risk for recognizing that drug as a foreign agent. It thinks it's a virus or bacteria or whatever, and it starts mounting an immune response to it. And by developing antibodies down the road, which eliminate the drug from your system. So people at risk for developing antibodies to their drug, if they have, if they're male, I believe, they're increased risk of developing antibodies. If you're on another immunosuppressant, it may decrease the risk of developing antibodies because you're suppressing the immune system, the body's natural immune system, in other ways, and therefore preventing it from developing more antibodies against the drug that you're trying to target. The underlying level of the drug may be low. So if you're not giving enough of the drug and the drug level is pretty low, that increases the risk of your body's immune system being less inhibited, and so it's more likely to develop antibodies. And sometimes if people have a very low albumin count, so albumin is a type of protein in the body, low albumin can be a marker of a really leaky gut and lots of inflammation in the colon, and they may lose drug that way and develop low drug levels that way, and that in turn may increase the risk of developing antibodies to the drug. So a lot of different factors there. So with regard to the first part of your question, how long can I expect for a biologic to stay effective? That really depends on the type of drug and the mechanism. I'll give you an example. So one of the first biologics that we use to treat inflammatory bowel disease fall under the class of anti-TNF inhibitors. So these are drugs like Humira, like Remicade, infliximab, et cetera. 33% of patients don't respond to an anti-TNF the first time they're exposed to the class. And 30 to 45% maintain remission at 1 year, meaning that they are clinically doing very well at 1 year. Whereas the other, 55%, 75% may not be in clinical remission. They may still have clinical symptoms. A third, so if you fall under the 2/3 of people who started an anti-TNF that do respond, then a third of those people will eventually lose response during the course of their disease course. In total, about 56% of patients started on anti-TNF will require another drug outside of this class during their lifetime. That's quite a lot. So I wouldn't approach these drugs as, I'm on Remicade now and I'll be on Remicade for the rest of my life. Things are very dynamic with inflammatory bowel disease. And they're dynamic in ways that we don't necessarily always understand. sometimes it's not really clear to us why suddenly someone developed drug antibodies. Other times it is. For example, if there are a lot of missed doses and drug levels fall to a low level, people can develop antibodies because they're not being immunosuppressed enough. So it really depends, I would say. But there is a risk of losing response to a drug, a very real risk of losing response to the first drug that you're on.
So I guess aside from maintaining your prescribed dose frequency, is there anything else the patient could do to minimize their risk?
I would say dose frequency, you're kind of catching us at a time within the past few years or so. The paradigm for biologics is starting to change with regard to when to test for drug levels, when to test for antibodies. Different gastroenterologists will have different opinions as to what the best approaches are, and different gastroenterology societies have certain opinions on the matter as well. Very frequently, I'll give you one side of the story. So there's a very strong, large group of gastroenterologists that feel strongly that it's all about drug levels and that we should be monitoring drug levels, because if it falls below a certain point, then that's predictive of developing an IBD flare, and that likely increases your risk for developing antibodies down the road. And so some providers advocate more frequently checking drug levels and drug antibody levels at certain time points in one's disease course to make sure that things are just at the right level. I think there's still more research needed to kind of convince the other side of gastroenterologists who feel like the data isn't there to support that kind of philosophy. It's tough. It's really tough. The rheumatologists, so the joint doctors who have been using all of these drugs that we use in IBD and who develop these drugs that we use in IBD, they use them first. They don't routinely check drug levels. So it's interesting. They don't feel the need to. They haven't found benefit, and yet with regard to IBD, there may be a benefit in checking drug levels pretty regularly. So to answer your question, is there something that you can do? Not necessarily. I guess it's more of an academic interest, to ask your gastroenterologist whether they believe in regularly checking your drug levels, even if you don't have symptoms, to see if there's any benefit to that. But know that it's an active area of discussion among IBD doctors and an active area of research.